Hello, once again we are into the discussion of the most common public health problem, that is diabetes. Diabetes is not only a disease of high blood glucose, but it is an inflammatory disease as we talked last time, and it is a disease of blood vessels. So, what is type 2 diabetes? We know that diabetes are of various types. There is type 2 diabetes, which is the most prevalent, or the late onset or adult onset diabetes. There is type 1 diabetes, which occurs in children, small children. Then there are other types of diabetes like MODY, that is MODY, maturity onset diabetes of young, where it is controlled by a single gene, where a grandparent, a parent and the next generation child or a young adult may be a diabetic. There are various types of diabetes. There is diabetes which happens due to pancreatic, chronic pancreatitis and pancreas stones in the pancreas. So, these are various types, but primarily we are concerned about type 2 diabetes, which is the major type of diabetes, or that is the prevalent type of, most prevalent type of diabetes in the society. So, what are the risk factors for type 2 diabetes? We know heredity is of course a risk factor, but it is a non-modifiable risk factor. One has no control over this risk factor. If a single parent is a diabetic, we know that the risk of the next generation person getting diabetes or becoming a diabetic is around 40%, 30 to 40%. And if both parents are diabetics, well, the chances go up to 70%. Another alarming fact is that if the parent has become a diabetic at the age of 50, there is all likelihood that the next generation is going to be a diabetic a decade early, that is in late 30s or 40. So, these are a couple of things one should keep in mind while dealing with diabetics or screening for diabetes. So, next question is, who should be screened for diabetes? Practically everyone, because if we look at the risk factors of diabetes, heredity, as we said, is a risk factor which is beyond us to control, but there are some risk factors like obesity. There are people with obesity, hypertension, that is high blood pressure, high cholesterol, people who lead a very sedentary life, they hardly exercise, they have sitting kind of jobs, they are hooked to computers and mobiles, and they are more in favor of, or they use more lot of junk foods. All these people are at a high risk of diabetes. And well, a very important factor, that is day to day stress. People who handle very stressful jobs, sleep poorly, are again at a high risk of diabetes. If we take women who have had diabetes in pregnancy, they are at high risk of diabetes. Women who have had large babies, that is babies weighing more than 3 kgs, they are again at risk of diabetes. So, if we take the population at large, most of us have a high risk of diabetes. So, practically everyone should be screened for diabetes at least from the age of 30 years. If there are 2 or more risk factors, for example, somebody has hereditarily a high chance of diabetes, has high blood pressure and obesity, well, they should start the screening much earlier, at the age of 20 or 25 even. So, this is the risk of diabetes. And type 2 diabetes, now coming to why and when should one control type 2 diabetes. So, what we practice nowadays, the modern medicine, it is known as evidence based medicine. So, the evidence we have in terms of a lot of landmark trials say that intensive and early treatment of diabetes is what is needed to avoid complications. Intensive, that is bringing down the blood sugars to safe levels, that is a fasting glucose of below 100 and postprandial glucose of maybe even below 150 and HbA1c of below 7 is desirable from the early onset of diabetes, because if we do not do this, there is something called a legacy effect or a metabolic memory, which results in more chances of complications in the future years. So, if we create a good legacy if we create a good metabolic memory early in the disease, then there is less likelihood of getting diabetic complications. If we take diabetic complications, they are broadly categorized into two: microvascular complications and macrovascular complications. Microvascular means pertaining to small blood vessels. The retinal disease, that is retinopathy, the kidney disease, that is nephropathy, and the diseases pertaining to the nerves, that is neuropathy, are the microvascular complications. If we take the macrovascular complications, if we take the larger blood vessels of the brain, a stroke is a macrovascular complication. A peripheral vascular disease, that is disease of the lower limb arteries, is a macrovascular complication. Then a heart disease or a heart attack is a macrovascular complications. Whereas microvascular complications are solely controlled by an excellent diabetic control, or you will be able to prevent those complications by giving an early intensive diabetic control. Macrovascular complications require the control of a few other factors, like control of hypertension, control of dyslipidemia, control of smoking, etc. So, if we take the diabetic complications, microvascular complications, we have said earlier that in order to create a metabolic memory, we must give intensive and early treatment. In our set of patients, or in our population in general, we all keep procrastinating and we delay the diabetic treatment. The patients tell us that let me try for 6 months, let me try for 1 year, and before we go on to a drug treatment. But there are absolutely no advantages offered by waiting forever. We can try a lifestyle modification, we can go on to a healthy lifestyle, we can incorporate exercise in our daily routine, sleep properly, adjust the whole lifestyle. But if that isn't working after 3 months of trial, we must think of a drug treatment. And what should be the drug treatment? Drug treatment, we all know, can be in terms of either tablets or insulins. Insulins was a big taboo, big no earlier, but now in last 20 years, there are a lot of people who come and say that well, give me insulin, I would like to go on to insulin rather than tablets. So, that is a very positive change that has happened over years, but whether you give insulins or whether you give tablets, the bottom line is control the blood sugars well and screen for the complications from time to time. So, who are the candidates who should receive insulin? Well, on detection, if you have a early very high blood sugars, or you have hyperglycemia, well, that is an indication to give insulin in order to prevent what we call as glucotoxicity. The high glucose itself acts as a toxin to destroy the beta cells of pancreas further. So, early insulinization has to be favored by the treating doctors and the patients. We know there are certain situations like type 1 diabetes or gestational diabetes, that is diabetes in pregnancy, where we can recommend only and only insulin. And certain situations in type 2 diabetes, when the patient is sick with other diseases, undergoing a surgery or is admitted, is critically ill, well, one has to give insulin rather than giving tablets. So, apart from these few situations, wherever the tablets fail, wherever the blood sugars are very high, one should go on to insulin. So, tablets or insulin, once again I would want to say that a good diabetic control is what we desire, and the screening for microvascular complications. Many of the diabetic complications are symptomless, if we take retinopathy, unless the retinal damage happens on the area of the retina where the vision falls or where the image falls, we may not have a symptom, or the patient may not have a symptom, but unless we screen, we would not know the presence of retinopathy. An early detection of retinopathy helps us salvaging a lot of retina. Similar is the case with nephropathy. Periodic screening in terms of urine microalbumin leads us to an early detection of nephropathy, and we can prevent the nephropathy from relentlessly progressing to end stage renal disease, where you can recommend only dialysis or renal transplant as treatment. So, any diabetic complication, screening is the most important key word, and screening should happen once a year. Already if you detect the presence of microvascular complications, the screening should be more frequent. So, diabetes is a topic on which you can go on talking for hours, but these are a few key points that I wanted to make. One is early detection and early screening, and once you detect, give a couple of weeks or months of lifestyle modification, and then go on to drug therapy with the aim of creating a good metabolic memory, wherein your patients wouldn't have, wherein the general population wouldn't have more complications. And the screening for complications also should be an integral part of diabetes treatment. We will meet some other time with a new topic. Till then, thank you.